Good afternoon, everyone. We're going to go ahead and get started. Dan and I were just talking about trying to leave room at the end for questions and answers. He said, "Oh, I'm going to have to cruise through." I'm like, "All right, we'll get started right now so we can ensure that there's time for comments and questions." So it is my great pleasure to introduce Dr. Dan Clark. He is an investigator in the IU Center for Aging Research here at Regenstrief Institute, an associate professor in the Division of General Internal Medicine and Geriatrics in the School of Medicine. Dan has been an IU CAR investigator, I think, longer than almost anyone, with the exception possibly of Chris Callahan. Well, with the exception of our founding director. So it is really my pleasure to have him here today to share some of the really innovative work that he is doing around health disparities. Dan has a long, really productive track record of doing work in the space of primary and secondary prevention with a focus on minimizing adverse outcomes, both health and cognitive, for disadvantaged populations, and has done a lot of work on intervention development in this space as well. So with that, I'm going to turn the mic over to Dan and let him share some of the work that he has been doing around social determinants of health.
Okay. All right. Thank you, Susan. So I'm supposed to say that I don't have any financial conflicts of interest, and that's actually true. I'm Dan Clark, as you've already heard. I have been here in April. It will be 30 years. And I'm going to use that as an excuse to do a little bit of weave some of my history in as I develop a framework for social determinants of health and put concepts around that framework to hopefully give us a little clarity about what that field is. And I think you'll see that this has been around a long time. It just has exploded recently and I've wondered myself, why did it explode? So part of what I'm going to do is think through, why did this explode in interest? And then I will put the projects that we're currently working on within that framework. So then when I talk a little bit about challenges and opportunities with those projects, you can see where those projects lie and how to think about those. I am also now in the Regenstrief Center for Health Equity Research. That's a new center funded by Regenstrief Foundation. It's located within Eskenazi, again led by Chris Callahan. And if we have time, I can give a little bit of an introduction to that. But I know that Chris is going to be here in a couple of months, I think it is, and he'll give more detail about that one. We are now trying to define a randomized trial that would be a combination of social and medical care interventions under that Archer Center. Okay, so my history. I came here in 1994, and my first NIH grant was an R29, which is now no longer exists. They're Ks now. This is kind of an early version of a K. And I'm sure I saw Bill. I'm sure Bill reviewed this before it was submitted, because he was one of maybe 10 investigators that I can recall being here at the time. It's very similar to what we do now. It was in the Blackburn Health Center. Providers screened patients who were at risk. We referred them to a church just around the corner where we provided a health assessment and health promotion intervention. So it's screening and primary care, referring to a new service that we provided within the community. That minivan is a replica of the one that I used to drive around and pick participants up and bring them to the church for this service. And my wife, who was a nurse, she's still a nurse, did the health assessments at the church. I'm pretty sure none of that would be allowed today. But I wanted to bring that up. So now thinking about history. So I said this has been around a long time. I just did some reading and found kind of one of the older references I could find. This guy, Rudolf Virchow, is considered one of the founders of social medicine. Now he's known as, I don't know this, but he's considered the father of cellular pathology, nothing I know anything about. But he was actually thinking in terms of health equity 200 years ago. And today, we know, most of us know that we have this objective of health equity, which is to improve fair and just to have the objective is to have a fair and just opportunity for everyone to achieve their optimal health. Now, how do we achieve that? That's an objective. The CDC recognizes what Virchow recognized almost 200 years ago, which is that we would need to address the social context, the historical context, and those structural forces that affect the distribution of resources. And I highlight NIMHD because we have a decent sized trial funded by NIMHD, but also because their definition of research in reference to health equity is about interventions. So there's a long history of describing disparities and health inequities. There's less of a history in intervention research to address that. And so we now have this social determinants of health framework for thinking about what is the cause of these disparities and inequities, but also what would be interventions to address those. So now, social determinants of health are the conditions in which we are born, live, work, play, and so on. Well, I was born, lived, learned, played in a very advantaged area on the northeast side of Lake Washington, which for those of you who know is in the Seattle area. It is now home to Microsoft. So when I was a kid, Microsoft moved in. This is constantly growing economically and in terms of social advantage. I didn't spend time in Seattle until I was working in summers in college. And I was working in South Seattle, that's the industrial part of Seattle, and I saw neighborhoods that were very different. Every school I went to was brand new. And I could see the homes, the schools, the streets, the sidewalks, everything was just much less advantaged than where I came from. So the opportunities were clearly different. And I didn't have a background as a child to have any frame of for explaining this contrast until I took a course at the University of Washington with Dr. Black. It was just an amazing course because he was born in Detroit, very poor, experienced all the racism you would expect, but made his way through school and to the West Coast, got his sociology PhD at UC Berkeley at the height of the civil rights movement, was very involved, and then came to the University of Washington and became just a fantastic lecturer. And so he really hooked me on social inequality, and I stayed with that interest through school and went to graduate school with that interest, where I got paired up with another amazing human being, which is George Maddox. He was born in Mississippi, volunteered in World War II, trained in England, landed D-Day +3, made his way through Europe, actually under Patton, came back to Mississippi, got his degrees, became chair of sociology at Millsaps College in Jackson, Mississippi, again in the height of the civil rights movement. So he witnessed many social injustices, and he had a strong interest in social inequality. He also had a strong interest in health. And so he brought me into the health field, and he really took me under his wing during graduate school and took me to England, took me to Europe, around the US, and I got to meet some of the early thinkers in this, what we now call the social determinants of health field. At the time, there were social epidemiologists and medical sociologists. So one of the thinkers that really influenced Dr. Maddox was Thomas McCune. And I'm sure some of you in school read some of Thomas McCune's work. This is post-World War II. England is repairing. When he's appointed the first professor of social medicine, England is repairing from the war and trying to figure out what are the health and social services going to be. And that's when he does some work, and at the time was a fairly controversial argument he was making, that it wasn't medical interventions that were improving life expectancy and fueling population growth. It was a rise in the standard of living for everyone. And eventually it became clear it was a rise in the economic standard of living, but also improvements in sanitary conditions. Now, this is a debate we still have today. Where should we put resources? Should we work on redistributing the social and economic resources that we believe are fueling health equity? Or should we keep targeting very urgent-oriented interventions and fairly targeted interventions? We could do both, and we should be. So after, during McEwen's time, Dr. Leonard Syme starts really exploding the field of social epidemiology. He was actually at the 2002 Turkey Run retreat that Regenstrief had, and he presented at the time, and I know that he talked about the need, and we didn't have this social determinants of health framework then, but he had done community interventions and worked on high-risk health behaviors a lot, plus all of his social epidemiology work describing disparities. And his thinking was certainly that we need to work with people who are at high risk, work in those communities, and we need to think about prevention, meaning more upstream. But he also was somewhat controversial. He went to the American Heart Association meetings. He was in NIH at the time in his early career, in the early 60s, presented his theory on the social conditions that affect cardiovascular disease, and he was chastised for it. He was told to stick to things that we know, like cigarette smoking. And ironically, about 20 or 25 years later, Linda George, who was also at Duke, presented work showing that actually social support or social isolation is as great a risk factor for cardiovascular disease as is smoking. I've seen it said that he's the father of social epidemiology, I think largely because of the students that he had who went on to do amazing work. So Lisa Berkman just done a tremendous amount of epidemiology work, and then Sir Michael Marmot, who I suspect many of you have heard about. Marmot had the Whitehall 1 and 2 studies, which are early longitudinal studies showing the association between social position and mortality. And he had a very homogeneous data set. He had British civil servants. They're all employed, they're all educated. Even within that homogeneous group, there was a clear gradient between social position and mortality. And then there's a lot of work that I'm not showing you. I'm cherry picking people I was exposed to, but there's a lot of other longitudinal cohorts that are starting to evolve at this time, showing just over and over again this association between socioeconomic status and health and mortality. Bruce Link and Fallon published in what's the top medical sociology journal, Journal of Health and Social Behavior, in 1995. This is just a year after I came here, a theory of fundamental causes. It's a fairly simple theory, and it's very consistent with what Thomas McEwen was thinking, with what Rudolf Virchow was thinking. It is the upstream social, structural, economic, historical forces, policies, legal system that shape the resources that communities would have available and access to, and that affects the conditions in which people are born, live, work, and play. And this happens over a life course. And it is the key to the fundamental cause theory is that it is access to flexible resources, community level, household level, or individual level, that allows you to combat a health threat or to take advantage of a health opportunity. And you can see this in the COVID pandemic. We saw great disparities. This theory would have hypothesized exactly that. And with the new weight loss drugs, this theory would hypothesize an increase in obesity disparities. There's already a significant disparity, but an increase now because people with flexible resources, with healthcare access, with information, with knowledge, with money, are going to be able to take advantage of these new drugs. So the initial impact of these drugs is very likely an increase in obesity disparities, which is a foundational factor of health and aging. And then I want to point out that in 2003, there's an important publication because it is an area level evaluation. So areas that are more socially deprived, socially and economically deprived, have worse mortality. But this is a longitudinal study, and it shows that actually the disparities at the area level are worsening over this period of time and have continued to do so. So we've not made progress on these disparities at the individual level or the community level. Then where does social determinants of health come from? This is a framework again for explaining how we might achieve this objective of health equity. And we're talking about health equity, not health care equity. So that's an important distinction. Sir Michael Marmot, again, chaired the World Health Organization report. I don't think this is the first mention of social determinants of health. I think the World Health Organization had a mention in 99 or 2000. I don't know if anyone knows for sure where this phrase came from, but this is sort of it wraps everything together. It's the World Health Organization, so it gets a lot of attention, and it's an easy thing to say, SDOH, and now it's got a package and a bit of a marketing scheme. But I don't think that's what was key, or it was one thing that key, but there was other things that made this kind of explode. And I just want to point out before I move on, Sir Michael Marmot was thinking community level interventions. He had a publication, he did a report for just the British Isles a couple of years later, and the interventions that he highlighted in there were not healthcare or medical care or even so much public health, but they're focused on improving the conditions in which people live and work, and especially in early life, because we're thinking upstream and prevention oriented. It's going to take a generation for these effects to show up. But what I think helped to explode this area of interest was the Great Recession, which came just after the WHO report, where disparities in poverty and other things just really was exaggerated. And then we had the COVID pandemic, where again, we see huge influence of disparities. And I think the combination of these things, and now a lot of funding from NIH and attention from CMS has made this just a very well-known area getting lots of attention. So this is a framework for these concepts. So upstream, we have social determinants of equity. These are the structural, economic, political forces that affect the distribution of resources, which then drive the conditions in which we are born, live, work, and play. These are far removed from the individual, but these are things that the individual and the family and the household experience. And it is what drives the distribution of flexible resources. That's fundamental cause theory in the middle. Then more downstream are health-related social needs. These are individual level things that we can measure. And this is where a lot of the healthcare focus on social determinants of health is placed. And this is an important distinction, I think, because I'm embedded with the Eskenazi effort. I know IU Health is doing a lot of things too. I'm not involved with that. But what I hear phrased as SDOH is very much individual level intervention. So it's a very healthcare oriented model where you assess an individual, you see a need, and you want to address it. Laudable and important. It is not technically what we would think of as a social determinants of health intervention. It's sort of the outcome of the SDOH effect and attempting to address that at the point of identifying it. And that actually is where most of our projects lie. So we have to think about what's the potential influence there. And one of the ways to think about the potential influence is to remember back about what has now become accepted evidence that health is influenced most by social and behavioral factors and the environment. Healthcare has, in the estimates you'd see, 10 to 20% impact on health. Social behavioral factors, 20 to 30%, environment, something like 20. You can find different publications that show varying percentages here. But the point is that the healthcare has a fairly limited effect. And in fact, there's a JAMA editorial by 2 NIH directors pointing out that in obesity, hypertension, and diabetes, which are 3 big things you would want to address if you were going to impact health and health disparities, that healthcare has made no dent in disparities in those areas, and in fact, they've worsened. And their argument is we've got to move outside of healthcare and work more with communities in addressing these factors. Then if you go way upstream, well, we have centuries of evidence. We started 200 years ago, but there's work further back. There's natural experiments. There are now some RCTs. It's going to take time to demonstrate the impact of interventions at this level. I think it will take a generation to show effects of these kinds of interventions. There are natural experiments like the child tax credit expansion that happened under COVID. That lifted, I've seen in some states, 40 to 50% of children out of poverty. So that's just a massive lever that can be pulled way upstream to address the conditions in which those kids are living. There's a guaranteed income trial, a randomized trial in Stockton, California that was done, where families for, I think, 2 years were given income. And there's evidence that resulted in less distress for the family and better mental health outcomes, all self-reported. So I think better assessment of those interventions and longer follow-up will be needed. There's also a moving to opportunities trial where low income, where people living in more socially deprived communities were moved into more advantaged communities, moved into housing in more advantaged communities. That was a randomized trial. The health benefits of that were seen in the children, but not until they were adults. So it took years and essentially a generation to see the benefits of changing the conditions in which those folks live. So potential for big effect, but also this is life course stuff that's going to take time. So that brings us back to what is being done with screening for social needs in primary care and increasingly in emergency departments and even within the hospital. And referring those who screen positive for a social need like food insecurity or housing insecurity, transportation insecurity, to a community service. This is a new area. And of course, the health system wants to see a far transfer of this social needs screening and intervention to health outcomes, but also to health savings. And that is, I think, a tall order. The Center for Medicaid and Medicare Services ran a large demonstration project, I think it was maybe 10 sites, to assess the effects of screening for these health-related social needs and then referring to community services. They saw nothing. There was no effect on health, but there was also no effect on the social needs. And one of the reasons there was no effect on the social needs is that few people actually took up the referred service. I think it was less than 1 in 5 actually followed up and enrolled in the referred service. And those who did noted the capacity of the service was limited, the quality of the service was limited, it wasn't tailored specifically to their needs. And these are things we've heard anecdotally in our Forks trial, that some of what's provided in terms of the food banks and so on, there's just limitations that affect willingness to access and willingness to access the service. Now, this is a new area, and I think there's opportunity to improve that referral experience and the access experience through a bit of a more warm handoff, and potentially through a little bit more of a personalized experience to get people to that service and keep them engaged. But there's a lot of work to be done in order to do that. And this is some of what the Eskenazi SDOH team, in quotes, is working to do. One of the issues here, I should point out, is that the data aren't there. When a referral is made, it's essentially into a black hole. Capturing where that person goes after that referral, whether they access the service, whether it impacted the social need, what happens next, is essentially gone. And that's a critical piece of information that is needed. Dr. Rivera, who's here, Dr. Rebecca Rivera, is working on submitting her K now that would investigate closing that loop so that those data would be retrieved and we would be able to track what's happening for those who have a food insecurity referral. So that's definitely an important piece of work. So these are where we have some projects now. And this is where I see these projects lying. So Produce for Better Health, that's PBH. That is a statewide program to get produce into produce delivered to low-income seniors. It was funded by Elevance Health. It's something Dr. Hickman connected me with. And it's actually something that, well, I'll hold that. I'll hold my comments on challenges and opportunities for a minute. I see that as a bit more upstream than some of our other projects because it is getting a resource to those. It's not changing the community in the sense that it's putting produce into the community or affecting access in that way, but it is delivering a resource, and it may free up other resources for the seniors in the home. And then our Forks is food resources and kitchen skills. We have our Forks team here today, and it's fun to see them. It is a much more intensive intervention. It's embedded within the Eskenazi FQHCs, but it's fairly intensive, and it's very much a randomized trial. It's pragmatic, but it's a randomized trial. So there's the challenges and opportunities associated with that I can highlight as well. Driven to Success now is a transportation intervention. This is an intervention that was developed by the community. We identified it and took advantage of that community service to pair it with the transportation screening that's done in primary care. And then we have the data then to know if people are accessing that service, using the rides, and what effect that is having. Again, that is very much a health-related social needs intervention in that the screening is done in the primary care sites, but it's also a bit upstream. It's a community level intervention. It's a new service that was put into the community by the community. So that one's a bit more upstream. And then the new Regenstrief Center for Health Equity Research will have a lot of work at the level of health-related social needs. It's also going to have a fair bit of healthcare equity work, where it's just investigating whether the services provided by the healthcare system are given equitably. That's a little bit more QI. It's not something I'm very involved in, but the part that I am involved in will be working on assessing the impact of health-related social needs, how to improve that impact, and how to tie into community services. Okay, so maybe I'll stop and see if people want to chime in with comments. If not, I'll keep going. But let me first say these are the people working in this area. I hope I didn't leave anyone off who's working on our projects. Lindsay Mosier is here. She's just an amazing research manager. She's involved in all of these projects. And then Jessica and Catherine and Donna are here, research assistants who are collecting data for our projects. And then we have great help from data management and Regenstrief data services for these. And then I want to highlight that Emily Dawkins at Eskenazi Health, Emily Dawkins and Mariah Adams have been huge in the development of the Forks intervention. They're very creative and had a big hand in what Forks is, which I can show you in a bit. And then on the faculty, I want to highlight a few of our junior faculty. So I already mentioned that Dr. Rebecca Rivera is working on her K in food insecurity and closing that loop. I see Dr. Brianna Sprague is here. Has a K pending that will address, will develop a stress intervention for minority adults. Stress sort of is a factor that works through all of this and has a foundational effect in translating the conditions that might be adverse conditions into adverse health outcomes. So that is a really cool project. And then Dr. Fairley Williams is very interested in social isolation and social support, a very important social conditions variable. And finally, then Dr. Armando Pena has a supplement pending to our Forks proposal at NIMHD, National Institute of Minority and Health Disparities. And then that is the Regenstrief leadership. I can go back and see, I just want to see before I keep talking if there's comments. I thought Bill might have one.
Hi, Dan, this is great stuff, and you've been working on before SDOH was cool. Two things. One is that there've been some focus groups and some published stuff suggesting that the term determinants pisses people off because it says that you're stuck there, and people are trying to change. But SDOH has been branded, et cetera. So people using the term drivers of health because they do, it's maybe a little less feel like you're stuck in a hole. That's not the main point I was going to make. In my department in Austin, I was chair of the Department of Population Health in the University of Texas at Austin. We got $1 million grant from ONC to close the loop on informatics between healthcare and social care. And we did that. So you refer somebody, the referral goes electronically to the social care provider, and it comes back to electronic health record as if you were sending somebody to a neurology clinic. That was really hard. And it's hard for a couple of reasons. Number one is that you have to establish a relationship with the social care provider first. And the healthcare clinicians, providers of all flavors, both clinical and non-clinical providers, have to know what to expect so they know when to refer the patients, the right patients to the right places, et cetera. And just having it available doesn't help if you don't know what it is and what it can do for your patients and have a discussion with the patient about why they should go there and what they can expect to get there. So, and there are a huge number of social care providers who do a lot of different things. So that's a huge lift. That took 2 years just to identify people and establish relationships with them. But then if you're working, this was done in a large FQHC network, there are a lot of people with social health needs. And all of a sudden you start referring these people, the people you're sending them to need more money and support to be able to do this. Otherwise, it's going to fall flat on its face. So it ultimately comes down to health policy and public policy. As you go from informatics up to legislatures saying, if you don't fund this stuff, then it's going to fall on its face and you're never going to close the gap in equities. And so the things that are happening now, how have they wrestled with these things and what can we learn from that and how can we make this path a little bit easier?
Well, the Ashkenazi team is behind you, it sounds like. They've been out beating the bushes to find these social services, understand where the opportunities are, what the community might see as the intervention needs, but is really so far struggling to narrow that down to a focus that would be a community level expansion. And the informatics part, I was hoping somebody here would jump up like Bill, but I know that the health data services now, not Loink. Actually, Loink, I didn't know Loink was here 30 years ago. This is their 30th anniversary. So, but I know that the Regenstrief Foundation gave new funds there to work on, I think, exactly what you're talking about. Well, the first part of what you're talking about, which is informatics, capturing the social drivers of health data, what happens after that referral. I see it as a huge need, and I agree, a huge challenge. And, maybe there's some new structure needed for what a community organization is, a social service organization is. Is there a need to do what you did 30 years ago and create standards for how data are recorded out there?
One of the key things is the community has to own the data.
Is what?
The community has to own the data. And so what we ended up doing is partnering with I'm blocking on it now, the United Way of Central Texas. So the database sits there, and
Yeah.
so when you refer a patient to a provider, it goes there first, and then it goes out and it comes back. But they own the data, and we partner with it. So having a community partner like that has a lot of fingers, different places, helps. Doesn't help with the funding part, but it certainly helps with the relationship part. But taking advantage of the social networks that are already there and have been completely separated from healthcare for a long time is the first place to start. And yeah, it's hard, but we don't do easy stuff, right? So you start a little bit at a time. Find one need, find some care providers, create a relationship with them, get them tied into this network, then go on to the next one. And then eventually over time they build, but it's more of a social network structure than an informatics healthcare thing. And it takes more disciplines for folks like you than folks like me and the other clinicians in here.
Yeah. Doing it one organization at a time is probably not a long-term solution. Does anyone else want to say anything? If not, I'm going to jump into challenges and opportunities in our project, some of which Bill already highlighted. Okay. So this is the Produce for Better Health project. It's, as I said, statewide. It works through the Title III Meals program. So it's an existing federal channel for distributing food. And it adds produce to that distribution system. And there's a lot of advantage to that. There was a recent JAMA editorial actually politely criticizing the development of health-related social needs screening and referral in the healthcare system. The argument being federal channels already exist for addressing food, housing, transportation, and the effort could be concentrated in those existing channels, not recreating new channels that might take resources away from those. And the examples they give are SNAP and WIC and other programs that could be ramped up. And one thing Eskenazi has done, which I think is one of the smarter things, is put SNAP counselors in the system so that when a person is identified as food insecure, they get a warm handoff to get connected, enrolled in SNAP. That is a very efficient approach, I think. So having that channel gives it high chance for distribution and sustainability. It's terrific. One of the challenges I see has to do with the rigor of the evaluation. So this was funded by Elevance, it was Anthem, it's now Elevance Health. The Area Agency on Aging providers, service providers, wanted the money going to the seniors, that's a great need. They're passionate about service. They want the seniors to get the food. There was no appetite for a rigorous design where some would not get the produce, or that some would get it in a delayed fashion, others get it later. So everyone's going to get the produce. But Elevance insisted there be an evaluation component. Otherwise, I'm not sure there would have been. So we worked with them to figure out what could we do. Well, what we could do was get people devices and let them do self-measurements and use Regenstrief's capacity to access medical records to track over time what's happening. And Faye, fortunately, is here and helped us figure out how to do that. And what we've seen is that blood pressure has dropped in a clinically meaningful way. But what I know is that much of that drop is related to now people having devices and having to record what their blood pressure is. So there's a self-monitoring effect that we can't sift out. And I don't think as I said, there's an existing distribution channel. This is a national network and they're presenting at their meetings these findings. I don't think the subtlety of the evaluation will be considered. So they're going to show an effect on blood pressure that would be meaningful. But I'm not sure that should drive future investments and scale up. And that's my concern, is that there might not be, a lot of the work that's done in this area could have less than adequate rigor, and that the evidence that some payers may want and use to decide about paying for these services could be less than ideal. So this is a case where a project was the intervention wasn't developed by our evaluation team, and the funding wasn't obtained by the evaluation team. We just came in. So that can limit things. And I want to also point out that Kaiser did put together a randomized trial to distribute produce. They presented at the American Heart Association meetings this fall. They did not report on blood pressure or weight. They said that's coming later. I don't know why they had to separate those outcomes, but they presented on A1C. And they had an effect, but from what I know and the readings I've seen, it would not be a clinically meaningful effect. It was a very modest effect on A1C. So I think it's yet to be known what the potential is. Despite that, there is a huge ramp up in the delivery of food, medically tailored meals, produce. There's even talk about Instacart and other corporations getting involved. I don't know if it'll ultimately be sustainable. That's something to be seen. Who's going to pay for this, and what will they want to see as in return? And will the evidence be sufficient to support that? So now we shift to a very different design. The Forks trial is what we all would expect in a randomized trial. It was developed by the intervention was designed by our team. We did the piloting, we pursued the funding, we have a rigorous design. It is pragmatic and it is embedded in Eskenazi. And Dr. Rivera led the publication of the pilot findings from that trial, which were quite good. It was just a single arm pilot. And if you want to know, I'll give you a brief overview, but if you can take a picture of this, if you want to see what the intervention really is for the participants, you can go to there's a WRAL TV clip showing what the dietitian is doing in delivering the Forks intervention. So participants randomized, all right, so Eskenazi has pretty aggressive usual care here. So anyone who is screens positive for food insecurity and hypertension will get the hypertension self-management education and support program and produce vouchers if they're in usual care. If they're in the Forks arm, they get that. They also get essential kitchen tools, weekly Mediterranean-style ingredients for twice-a-week cooking classes in low sodium, low carb, Mediterranean-style cooking. And they prepare those meals together over video conference with the dietitian demonstrating in the FQHC kitchen with an overhead camera how she's preparing these things, and as she does so, gives lessons in nutrition. They get to do this, learn how to prepare it, and then sit and eat the meal or taste the meal together. And fortunately, we're seeing good satisfaction in our team. I don't know if they were just being nice to me, but they think this seems to be a little bit more satisfying intervention than what we've had in the past in terms of these health education, health behavior interventions. So it's a health-related social needs intervention. It's identifying the need at the primary care site, but it is then very much an individual level intervention, and it's focused on health education, health behavior. So the good things here, the opportunities, that we were the creators, and so it was built on evidence. It's kind of an edge of the water thing, although there's starting to be more and more of this now. It is embedded in the FQHCs. And of course, we have the rigorous evaluation. The downside, this took us at least 2 years, I think more than that, to ultimately get funded. This was supported by Regenstrief funds and division funds, through much help from Dr. Sachs. The reach is still a challenge. So I was hopeful that we're working with the community health system. They're doing mass screening of food insecurity. We're going to deliver food to the home, provide this experience. I thought it would be easier to enroll than it has turned out to be. It is still difficult. Even with some of the dietitians making some of the outreach, that certainly helps because so they know those dietitians who have met them, but it is still a challenge to enroll. If we did have no consent, I don't think it would make a huge difference in our rates of enrollment. I think it is just hard to find people who are very ready for a fairly intensive intervention. And so the question really is that scalable, and can it really be implemented and make a large dent and have high reach that would be needed to do that? And of course, it has all the external validity challenges you might have with a randomized trial. And my big question is, it's going to take us 4 more years to finish this trial. Is that going to be relevant? CMS may already be paying for food deliveries by then, and this won't make a dent. But it also could show, something that is valuable in addition to the literature. I don't think there's another trial ahead of us right now in this area. There are certainly some single-arm studies that have done this and other demonstration projects around medically tailored meals. Most have shown some positive benefits, but I think this trial is a bit out in front. Okay, so now here's another project. This is again different. So I picked these projects because they're all a bit different in how they were created. This is a transportation intervention that was created by the Pathway Resources Center, which runs the Driven to Success transportation intervention. This was created by the community. We had nothing to do with the development of this intervention. It operates in the Far East Side of Indianapolis. And so it has credibility. It's led by Counselor Jackson, who's the CEO of Pathways Resource Center, and also oversees Driven to Success. It's very different in the sense that it is very embedded in the community. It is a ride service, operates 5 days a week, sort of 8 to 5, and you can have a ride anywhere within the Far East Side area. You have to call and schedule, well, you don't have to call. You get online and schedule your ride, and within a 30-minute window, you are picked up for the ride. It costs $2 per ride. So that sounds amazing. That is not what it costs Driven to Success. It is more like an Uber level cost for Driven to Success. They have grants to pay for those additional costs. And so the question is, if you were to scale this up, who would pay for that substantial ride cost? And so that remains a big question. We paired with them to study the influence of rides on new and expecting moms, because they have a high frequency of pre and postnatal visits. We thought there'd be the best opportunity there to see whether providing transportation would increase those healthcare visits and improve outcomes. This is just a feasibility pilot. There's no randomization here. We're seeing whether people will enroll in the service and use the rides. If we identify people with transportation insecurity in the healthcare setting, reach out to them, so sort of a warm invitation, and assist them in enrolling in this ride service. We can do it for people who speak Spanish, English, or Haitian Creole. It is taking Eskenazi staff to do that piece, so it's even more expensive than just the rides. And we will track ride use, satisfaction, and see what happens to visit rates. The challenges and opportunities. Well, as Bill was alluding to, these community organizations are all different. And they store their data different. They capture the data different. They have different insurers. They have different rules and policies. And we have 4 organizations involved here. Regenstrief is providing the funds. Driven to Success, the service. IU has its usual research regulations. And then Eskenazi Health has staff budgets, contracts issues, data security issues. And we could not anticipate all of the things that were 4 organizations until we just dove in and started finding out. So it took a while to get this going. And I already talked, I think, about the opportunities, about what's positive here. Again, I'm not sure if we see an effect, or let's say the rides are really satisfying and they're very much used and they get moms to their visits, it's a bit hard to figure how to cost that evaluation. That service. And there's a new, I'm sure some of you have seen this NIH RFA for SDOH interventions that is just out, and they're due in 6 weeks, so you have to hurry up. But I thought about this one as a fit for that. But I had trouble figuring out how, under that grant mechanism, we would pay for an expansion of that community service. I would also be nervous about depending on Driven to Success maintaining its grant funds for that service over the course of a 4 or 5 year NIH trial. And I also think it's a stretch to think that we could get these 4 organizations on board in 6 weeks for a grant submission. There would be a lot of details to work out, and who's doing what, and the staffing and the budgeting and so on. So there's opportunities at the NIH level. I see some challenges in meeting those opportunities. So here's my kind of conclusion. So we went through a few projects that are all a bit different, and we went through an SDOH framework that thinks about what's upstream, what's downstream, and how those are related. There is a long history to the social determinants of health work, not necessarily to that framework, but you could see a 200-year history in thinking about social conditions and how they affect health equity. And there's a lot of new work, a huge ramp up in the health-related social needs work, which is individual level almost entirely. It's not community level intervention, so not technically social determinants of health intervention. And there's a big need, as Bill talked about, for figuring out how to have the data that would allow us to better evaluate the impact of those health-related social needs interventions, even though at the individual level, they could address those urgent social needs while at the same time, policies, regulations, structural changes could be taking place more upstream and address social determinants of health. Now, one of my concerns is that because the healthcare system is ramping up this effort at the whole health-related social needs individual level, is that we could repeat mistakes that I think have been made for decades in the health disparities and lifestyle intervention fields, which is that we focused on individual level. And if this work by the healthcare system takes attention off community level upstream factors and we don't fuel investments there, which may require some redistribution of resources through like the child tax credit and many other things. I think this work could end up only addressing urgent social needs and not making any difference to what's coming in the future in terms of disparities and people are being pushed into the stream and flowing on downstream to create just a greater volume of social needs that would be in need of being addressed. So that's my thing. And then let's see if there's questions. This is sort of the objectives of the new Regenstrief Center. for health equity research funded by the Regenstrief Foundation. So we have a few minutes if there are any questions, or maybe someone can offer some comments or details if they'd like. Who's in charge? Yep, I'm whatever. I'm not, I don't feel like I'm in charge, so I don't.
And what a health equity can do, but also the history that you gave. That was really interesting. So thank you. I wanted to ask you, just because sort of thinking through the sort of details of the programs that you're talking about, the better Produce for Better Health. That's, you work with the foundation, Produce for Better Health. Is that right?
Yes.
I was thinking about what you're saying, because I think it's an interesting challenge, this notion of like what's upstream, and maybe we're not going far enough upstream. This foundation, of course, is a the person who runs it was formerly at Monsanto. It's basically a list of the whole board is basically big ag corporations, Monsanto, these other kinds of companies, right? And I understand their profit motive for wanting to show that their growers' produce has has good health effects, and that makes sense to me. And it makes sense to me that academia could provide that information if that's what the government needs, and that would also benefit their business. When I think about upstream, though, I'm wondering about what is producing these kinds of distributions of power. Because there's other kinds of programs I think some of us are familiar with. I mean, I'm sure you're familiar with, there's these programs where communities work to grow their food. They have, community gardens, which are good for health too. They have all kinds of initiatives, right, to reserve land, to pay for small farmers, this kind of thing. When we think about this program, right, what it's doing, it sounds like to me, is there's an argument to be made, not the only argument. There's argument on the other side too, but some researchers, of course, outside of health world, in labor and in economics and so on, right, have said that essentially those distributions of power that are producing these bad effects are directly related, right, especially in rural areas, to to what Monsanto and Bayer and all those people who are on the board and all these people who are, what this organization is doing. I'm wondering why you would work with a sort of these big agriculture, because it seems like if you're going to think about why people can't afford food, who's driving down wages, right? Who's raising the costs of food? And that's concentrated wealth in the agriculture industry, arguably, right? Other people would argue no. But if you accept that argument, then it seems like the whole upstream problem sort of appears here, where upstream, what's happening is that we are, there's people who are going to be coming to certain states. They're, refugees from the rural mess that Bayer and Monsanto made in Latin America. They come here, and then we sort of pay those, we transfer, tax dollars, essentially. That's the argument that's being made here, right? To those sort of big growers who then take that profit, make more mess, and then do it. So to me, that's the upstream problem. And to intervene, and this is why I think that for a health system to intervene, or health research institute to intervene, they have to think about not just what's being done at that sort of downstream level. Like you're saying, I'm sort of inspired by what you're saying, just to sort of think through that logic. But also they have to think about how the health research and how the health knowledge as it's being produced is either changing or not changing what's happening upstream. So I want to ask you about, is the kind of research you're doing with this organization something that could be done with smaller groups of people, more local groups? Is there a reason why this sort of bigger organization was chosen? Like, what happened there?
Well, great points. It's probably a catch-22. I mean, in my mind, it'd be a catch-22. If we don't work with large organizations, I think the potential to scale is very limited. I think if you really want to affect access to produce, you would work through large channels that would have the capacity to address the costs of quality produce and nutrition. And that's the USDA by and large. And there's plenty of evidence to show that the cost of a nutritious calorie far outweighs the cost of a low quality calorie. And getting produce into homes is one strategy. A better strategy would be more upstream and putting quality produce at an affordable price within reach of every community. They talk about food deserts. They're not really food deserts. They're nutrition deserts. And that's work that I think would require big policy changes and very upstream. If we provide evidence, I commented that I think it will be relatively low quality evidence. But if the evidence drives an increase in the produce and nutrition that gets into the homes of low-income seniors, I see that as positive. But definitely those more upstream things would be needed to make a much bigger dent in the quality of the diet for Americans than anyone else. But thank you for that input. Okay, any others? Thank you for listening and thank you for showing up.